for the next few minutes. Thank you.
Yeah, thank you so much, Dennis. My name is Dr. Sam Muga. I serve as Deputy Chief of Party in the USAID-TB Act 2 activity. I am doing this on behalf of my team. And as part of the presentation, maybe they will just stand up and give me a thumbs up so that I make sure that I'm being given the support. All right. Thank you, team. So Iban has mentioned to me that lazima nisome hii kama taarifa. But in moving fast, I also request that we give the presentation adequate attention, so that I'm not just, moving very fast over it. So for USAID-TB Act 2 activity, we are currently working in our extension period. And this is considered year 6 in quote. And we work with various key partners and sub-recipients. We have 3 sub-purposes, with our main goal being to reduce the incidence of TB and deaths in Kenya. And our sub-purposes cut across increasing timely use of quality TB, TB-HIV, DRTB treatment, improving participatory approaches, and enhancing the efficiency of the National TB Program. I acknowledge the partners that we have, and these strategic partnerships have been very instrumental in making a difference in the work that we do. Our interventions are aligned to the National Strategic Plan, and we are very glad that we played an important role in making the new strategic plan come to life the way it has, and still looking forward to the plan being implemented at county level. Under sub-purpose 1, a quick summary of activities that we have been able to do. We have focused on drug-susceptible TB, and here we have done a couple of activities that include data reviews, PQE technical missions, supporting TB screening in high-risk groups using chest X-ray and TrueNut, and other activities including development of a patient information package. We have engaged in a couple of technical assistance missions to counties. In the period, there were about 5 of them, and we have engaged county staff, the CTLCs, SCTLCs, CMLCs, county pharmacists, and CDHs, and that has been the area where we have been supporting a lot. A deep dive into our counties, we support 4 regions, 11 counties with several facilities outlined in the map. And in this area, we do a lot of capacity building, and in the period we capacity built about 17,383 healthcare workers on various areas, CMEs, sensitizations, trainings, and DRTB meetings. So in these counties, we also provide coordination of stakeholder forums, group meetings, data reviews, and we also seek to leverage resources to enable the work plan that we plan to implement to reach the various beneficiaries. We also provide logistical support. In this period, we supported tools, distribution of medicines, support supervision, and even commodity security meetings. Further, we also support supervision, logistics, and regional work plan development. PQE has also been a focus for us, particularly for active case finding. In the 10 pilot counties, we participated actively in the period and also supported report writing, where we looked at documentation of the strengths, the gaps, and the recommendations. And this would form a platform for future implementation. The draft report is undergoing review. As part of support to the counties, we also implement interventions. One of them is digital adherence technology. Here you can appreciate some work going on in Mombasa, in the coast region. DAT is implemented in Nairobi and Mombasa. Some outcomes, we reached out and engaged to 228 facilities and enrolled 4,265 with a breakdown by gender, men being more. And we have learned a couple of lessons from DAT, which included that it helps us foster the patient person-centered approach that we envision in our NSP. It's a good opportunity for differentiated care, and it also helps us to improve outcomes both in DSTB and DRTP, particularly in populations of poor adherence. Further, we have supported PMDT, and here we have done committee of experts meetings, workshops for review of guidelines, technical assistance, clinical review meetings, support of lab logistics to Lancet, and specimen referral. We also participated in the GC7 application and supported the PMDT write-up for the country. As we speak, we are engaged also in the drug resistance survey, and here we offer technical support, which includes review of the protocol, various commodities, and even logistics for the staff and NTRL. Under childhood TB, discussions have happened in the COE, which we provide technical support to, supported consultants for the new childhood TB guidelines in alignment with what WHO recommended, and further did task force meetings and training curriculums, and also capacity built 94 TOTs from all the counties, and further went ahead to facilitate the county-based trainings of CHMT, SHMTs, and frontline workers, and also participated in giving technical support to the GC7 application. Under strengthening the diagnostic network, we do monthly bundling of about 248 machines, participate in the diagnostic COE, support 51 gene expert super users, review the various manuals that support diagnostics, and also have done refresher trainings for the medical lab technologists. This is just a summary of some of the activities under the diagnostic session, and we supported DNO, Diagnostic Network Optimization, DNA, Diagnostic Network Assessment, EQA, and also technical assistant missions by NTRL. This just fosters the point of what happens in the diagnostic area. The addition here is we have participated in the dissemination of referral, sample referral guidelines, and also the quality management framework for the diagnostic networks. I know we have had several discussions about TrueNut, and there are very many promising results coming out of this. We all know the uses and advantages and limitations, some of which include the cost effectiveness, patient access, it's efficient use of DNA, and it can be used remotely. These are some of the results coming out of the support we have given, and you can appreciate that MTB positivity has been on the increase with the use of TrueNut. We have also supported 2 sites with IGRA in the period, and it helps us to have perspective in preventive therapy and targeting high-risk groups. The positivity of IGRA performance as at March 2023 was 37 to 57%. And we appreciate the 2 counties, Nairobi and Kajiado, for the good work that they have done in this. Digital X-ray is also an important discussion that's ongoing. And under digital X-ray, we have positioned 8 machines, strategically positioned to address the needs of particular populations in Turkana, Siaya, Kisumu, Mombasa, Kitui, Meru, and 2 in Nairobi. The 8 pieces have been very useful in giving us perspective in terms of efficiency and also identifying cases. Some of the key activities under chest X-ray that we have done include a review meeting, on-job training, X-ray reading and reporting by consultants, bringing safety equipment, closing out INTP in relation to chest X-ray, renewal of licenses, dosimeter reading and technical assistance, and even replacement of parts. Some of these activities inform the frontier of how the country will be proceeding in terms of implementation of chest X-ray. Some results from chest X-ray is that we have managed to screen about 50,163, and we were dealing with a cut score of 60%, 60, and the yield, the 32% positivity yield has really been promising in terms of finding the missing cases. Some key lessons that I can share about chest X-ray is that collaborative planning is important, a focus on safety standards, and it's a capital-intensive approach. You can't just take a machine and just place it somewhere and say it will work. And these lessons are being shared as we proceed to scale up. Under raising awareness and demand creation, we have done quite a bit of advocacy. So we have engaged with county and health political leadership on health financing in various forums. And we also engaged in the Devolution Conference, which was an important milestone in terms of supporting the counties. We also participated in the UN General Assembly, UNHLM, in September. And we did this in collaboration with the CSOs in country. Further, we have engaged in MTEF discussions and also the health legislation for domestic resource allocation and the multi-sectoral accountability framework, which we continue to drive and support. This is just for you to appreciate the engagement of the community in our advocacy approaches. And here, Naomi Wanjiru, a champion, was making a submission in the plenary. In demand creation, please do this for me so that I know I'm still with you. Thank you. In demand creation, we have engaged influencers. Here you can see Awinja, and we engaged with other, Flaco and the rest, I know you know them, to be able to pass a message regarding TB, and we have reached about 10 million. And 17 million also reached with our empowering success stories, and over 1,000 reached with IEC materials. In demand creation, our strategy has focused a lot on infomercials, which we have done. We also support the World TB Day. The TB newsletter, which I saw our head of program has also shared with stakeholders, and making sure that what we have done in our various projects are also shared with others for stakeholders to engage with. In the private sector and community partnership, we have focused on the workplace model for PPM. It is part of our deep county support. So apart from PPM, in addition to that, the new project TIFA, which I know you are aware of, which focuses on cross-border populations, also focuses a lot on our deep dive support in the counties. The counties under which PPM support is available is Kajiado, Kericho, Kilifi, Kisumu, Laikipia, Machakos, Meru, Mombasa, Nyamira, Nakuru. And for TIFA counties are as listed: Busia, Bungoma, Trans Nzoia, Turkana, West Pokot, Siaya, Homa Bay, Migori, and Kisumu. We align ourselves to the workplace policy in the workplace model. And the idea is to systematically engage these workplaces and provide guidance and integrate TB services. Companies that have been mapped are 478. And you can appreciate that various counties have a number of companies that we have engaged with. TB cases are also displayed on the trend graph just at the end. And this work continues to be scaled up. We try as much as possible also to use the clinics that are available in these facilities and the healthcare workers to continue to help us to implement. Part of the package that we engage with in terms of the PPM model includes creating awareness, sensitization, and capacity building, having forums where they can do experience sharing, the multidisciplinary approach, engaging disciplinary experts like the public health officers, health promotion, and community focal persons, and then doing networking and supporting the outcomes. These are just some of the results that you can appreciate in form of a cascade for the engagement of the workplace. We have notified about 336 patients. In supporting the national TB program and enhancing efficiency, there are a couple of activities we have also done which include support supervision and coordination. And just listing these activities, supporting all the TB coordinators in terms of logistics, supporting the NSP workshops, GC7 grant writing, the PARTS conference, and the MAF accountability framework development. We have also supported TrueNut engagements in 38 county laboratories, including trainings, IGRA that I have mentioned, and also connectivity for all the machines in the country. On commodity support, these are the key areas that we have managed to support. So forecasting and quantification, technical support in the meetings. We have done emergency drug distributions and also support for airtime for coordination of this area. So this is just a picture speak of the technical support and activities we have done. So NSP, engaging with CSOs, the grant writing, and various other forums that showcase the activities we have managed to do. We also use data for decision making and support that also. And the focus here is to promote a culture of collaborating and learning. Some of the activities are as listed, so TIBU support, license renewal, NSP writing, printing of tools, annual report writing, annual joint work planning, NSP planning, global fund writing, and capacity building. Under TIBU support, we do the following. So just supporting TIBU managed services, airtimes and bundles, bulk SMSing, and making sure that everyone is supported to engage fully with the TIBU Command Center. Under operations research, we have received approval for our protocol, and in the period we have engaged significantly with presenting pieces that showcase what we have been doing in the country. A key highlight here is in the Union Conference, where we supported a couple of team members. Professor Obimbo was one of them. Dr. Lorraine was also one of them. Kennedy was also one of them, just showcasing what we have been able to do. On INTP, I know I have already mentioned about DAT, TIBU LIMS, and IGRA, and TPT, and chest X-ray. We have closed this project, but we have had very good enriching lessons that are good for the country and other stakeholders. And we know why we were a focus as Kenya for the introduction of new tools. TIBU LIMS as a connectivity platform has been very useful in bringing all the information about the machines we use in the country. GeneXpert, TrueNut, chest X-ray, name it. And this has enabled us to have a dashboard where we can be able to view our data. Key activities were, deploying TIBU LIMS, providing technical support, and using that data for various report writing processes. I had mentioned TIFA. This is a new project that we are launching starting next week. And it aims to address the needs of the cross-border populations between Kenya and Uganda. And we are hoping it forms a very important platform upon which we can continue to build processes to help our cross-border populations. It is coordinated by the National TB Program and IGAD, and CHS is a sub-recipient of JSI. New areas of focus. So CHS is focusing a lot in aligning TB and HIV programming to PHC and universal healthcare. And we have held one session where we've had technical expert discussions regarding that particular strategic approach. We are committed to continue to provide logistical support in the various areas, so TB, TB, HIV, DRTB at a national level. We are also keen to continue to have deeper engagement with a focus on the counties in the various areas and continue our collaborative approach with NTP, USAID, and other partners. And we're also keen to be a front runner in testing new models as aligned in the NSP, bringing in the patient-centered approach, new innovations, multi-sectoral engagement, and also still remained aligned to the overall goal of reducing incidents and deaths. That is my last slide, and thank you very much for listening to the TB Act 2 presentation. Asante sana.
Wow, thank you so much, Dr. Sam. Fungueni moja, fungua, tuende. Thank you so much, Dr. Sam. We'll take another presentation, then we do question and answer once. So I want us to welcome Health IT to do their presentation. Haya, kila mtu anisalimie tafadhali. Kila mtu anisalimie kutoka sehemu hii. Musiboeke. I want us to give Health IT concentration a bit. And I'm really happy I can see 85% of us are not on laptops. You are listening. And kindly take note of the key concerns. And if you get a concern has already been addressed, kindly don't repeat. So as he sets up, let's give Hesbon this opportunity. So Hesbon.
Good morning, ladies and gentlemen. All protocols observed, I want to take this opportunity to bring to you Health IT presentation on behalf of the Health IT project. We have Health IT colleagues in this room. I just want to ask them to rise up as part of this presentation and as part of the team that has been working round the clock, supporting this particular event. Health IT. Thank you so much, colleagues. I know our chief of party will talk when time comes. He's over there, that end. Thank you very much. So without much ado, I want to go straight into the Health IT presentation to give you a very quick overview of the Health IT project, and also get into the activities that Health IT project has been able to undertake over the last 3.5 years that the project has been funded to support a TB program. I will also be talking about the achievements over the same period of time. So the Health IT project is funded by USAID to support health information system strengthening at the national level, county level, and down to the very first level of healthcare, that is community level. The funding started in 2016 and going on up until September 2024. This is the 8th year of implementation of the project. The TB funding started in October 2020, and therefore this is the 4th year working together with the TB program as we support health information systems within the TB project. Health IT is domiciled at the University of Nairobi, with UNES being the prime recipient of the grant. And of course, within the University of Nairobi, we have the project drawing a lot of technical support from the School of Computing and Informatics, given that the work that the project, the core work of the project is really to support, provide technical assistance in digital health. The goal of the project is to contribute to evidence-based decision-making by healthcare providers, healthcare stakeholders in the country. This being a goal that Health IT is able to meet by ensuring that data is captured digitally. We support a number of systems or a number of digital platforms that provide instance for data capture. We support systems that provide reporting from the facility level. We support systems that provide data for decision making. It means that users are able to access the data and be able to use the data for decision making. Just beyond the TB program, our support goes to the bigger Ministry of Health to be able to provide the platforms that I've talked about, and of course maintaining these platforms in terms of ensuring that the systems are available for the users at any particular time. And of course, the other support goes to the Ministry of Labor and Social Protection, in which we have the Child Protection Information Management System that we support. But for the sake of this audience, I'm going to concentrate on the support that goes to the TB program in particular within the Ministry of Health, and how the project has worked over the last 3.5 years to be able to support health information systems within the TB space. I just want to highlight that we work with a number of other universities, 7 of them across the country. This being a very unique model for the project, that is county proximate universities that are spread across the country to be able to support the counties. And I will be talking about this just to be able to emphasize how the TB program would be able to benefit from the county proximate university support. The goal of the project, as I mentioned earlier, is to contribute to evidence-based decision-making by health sector stakeholders in the country. And to be able to meet this goal, just want to emphasize on the purpose of the project, which is Kenya's health system strengthened to be accountable, to be efficient, to be accessible, to be inclusive, and self-financing. When we look at the purpose, and we are talking about health systems to be accountable, one area that I want to draw your attention to is data. When we have data, data is able to tell us what is happening across the various interventions that we have for TB. And we have systems that are supporting TB interventions. We have TIBU that is used to be able to capture data. Of course, we have the TIBU Lite that is now a point-of-care system that healthcare workers are using to be able to capture data. And then the question is, how do we ensure that the data that we are capturing in TIBU, the data that we are capturing across other systems, lab systems that we have, is able to provide information to us to demonstrate accountability? When we have put resources in TB intervention, how do we ensure that the data will be able to reflect that? So in us meeting the goal of providing, or rather contributing to evidence-based decision making, we need to look at, we are looking at the fact that health information system should be able to provide data that helps in accountability, provides data that helps in efficiency of providing interventions. And so that is a question that I want to leave to the TV fraternity, that how do we ensure that even as we use these systems, as we have healthcare workers using these systems, and we use the data, is this accountable? Is the system ensuring that we are efficient in the way we deliver interventions? Just to highlight very briefly in this results framework, where we have the goal at the top, we have sub-purpose 1, looking at the various systems and the support that goes to the various systems. That is to my left, or rather to your left. We have the second sub-purpose, looking at capacity building. So those are the 2 core sub-purposes that we have within the project. And my presentation is going to, when I'm talking about the achievements, the achievements and the activities that we have had will hinge around the two sub-purposes. Just to highlight very, very briefly how we have been able to organize our work as Health IT project to be able to support the bigger Ministry of Health, and in particular for this case, the TB program. We have this digital platform ecosystem that highlights the key areas of our work. We have the digital health infrastructure, very important here, which provides us with the system, provides us with the platform where systems are hosted. We have data centers, we have servers that are hosting these systems to ensure that the systems that are hosted are available at all times. Within that, a key area we're looking at is security of the system or the data centers, such that no unauthorized intrusion into these systems. The other aspect, as I move on quickly, is looking at standards, open standards. The systems that are supported by Health IT are free and open source standards. We have a number of systems. One of them is KHIS. I'm mentioning this because I know that most of us in this room have used KHIS at one time, either directly by having access into the system or indirectly by having data extracted from KHIS in our TB programming work. We have the Kenya Master Health Facility list that is also in use. This being a registry of all facilities in the country that provides us with information about the location of the facility, about the services that are offered at the facility. And moving quickly, we have the other aspect, which is smart health data. Data that is captured in the system is analyzed and packaged in a way that it can be used beyond the point of data capture, such that other users at the facility level, county level, and national level, and even stakeholders are able to look at this data and use it in decision making. To be able to improve the systems, we have the aspect of system evaluation that looks at being able to get user feedback on how the experience of the users on the system, and how are some of the user needs that need to get into the system. And finally, there is the aspect of capacity building that we are looking at to ensure that once the systems have been deployed, sufficient capacity is built for the users to be able to proficiently use the system. And at the lower level, we have the boxes that are highlighting the environment in which all that I've mentioned sits on. There is the legal, there is the policy framework that we have to be able to guide use of data, to be able to guide what kind of systems we are deploying. For example, if you're using TIBU, is it following the laid down standards? We have a number of other frameworks, for example, the interoperability framework that provides the data exchange standards for us in the country. So we have within the digital health ecosystem, we are looking at a number of areas, but also there has to be that legal and policy framework in which we operate. I talked earlier a little bit about the county proximate university, and the vision of the project when it was set is to ensure that because there is a very lean team at the University of Nairobi, how do we then reach the entire country? And that is how the county proximate university model was brought into action to be able to have the capacity within the universities that can support the counties where the universities are located. So the county proximate university model looks at providing technical support, providing capacity building, supporting HIS evaluation across the country, and specifically to the counties where these universities are. A very quick highlight, just to mention that we have 7 universities. We have Maseno, we have University of Kabianga, Rongo, Must, Chuka, Kabarak, and TUM. And we have a number of faculty that are supporting the project in these universities, together with interns who are supporting the project. To date, we have had about 92 interns going through the county proximate universities. And I know the main question that you could be having is that how can the TB program benefit from the county proximate universities? First and foremost is really to look at what are the priorities at the county level. What are the priorities of the TB program? And our universities provide skills that you can benefit from in data analytics. You can benefit from technical support that the teams provide to the facility, to the facilities. You can benefit from the capacity in evaluation. If you want to conduct an evaluation or you want to conduct operations research, you could benefit from the knowledge that we have within the universities. Very quickly, I want to get into the activities that we have conducted over the last 3.5 years and look at the achievements that we have had. Under sub-purpose 1, where we have system evolution, that really is developing systems either from scratch or we have enhancement of existing systems. One area that we have worked with the program is the upgrade of TBU Cache that is supporting the program together with the implementing partners. Health IT has worked to look at what are some of the areas that require enhancement with the TBU Cache to be able to meet the user needs. This was done, and as we speak, the user acceptance testing of the enhancement has just been completed, and very soon we are going to have the upgraded TBU Cache to be able to support the user needs that were identified during the reviews. We have the aspect of the website needed to be upgraded, and so the project supported this to ensure that we have a website, not just for the sake of it, but have a website that would be used as a dissemination tool to a wide audience. And of course, if you look at the current website, which has now been upgraded, it is more dynamic, it is more vibrant, and not just a place that information is there, but very resourceful in terms of the materials that you are able to get, very interactive when you are looking at the website as it is now. There has been review of the dashboard. There has been review of the existing TBU dashboard. This process was completed, and what is pending is to really get into the actual work of getting the dashboards upgraded and being able to meet the user needs. A very core area of our work has been in systems interoperability, and we have worked together with the program over the period that we have had TBU and KHIS exchanging data. We have data sets that were mapped so that TBU can push this data into KHIS. The core reason for this is that the wider reach of KHIS has a wider reach in terms of those who are accessing data from KHIS. Unlike TBU that has a smaller reach, we have data that is quarterly pushed into KHIS from TBU, and therefore this makes data available. And of course, this comes with a number of benefits for the TB fraternity, in the sense that there is comprehensive data that when you're looking at KHIS, you're able to look at data in KHIS that is coming from TBU if you don't have access to TBU. Of course, this avoids the process of having to have redundant procedures of, again, getting data or manually entering data in KHIS. Or if there were some tests that have been done, we don't have to repeat that procedure if we already have data that is being exchanged between two systems. And of course, it makes quick and easy access to information. If you are in one system and all the data is there, having been imported from another system, you are able to easily get that data. So this is a process that has been going on, and the work that Health IT has done in this process is to ensure that if there is any upgrades that have been done in KHIS, the upgrade will ensure that data that is coming from TIBU gets into KHIS. Also ensuring that KHIS is maintained, that it is accessible at all times. In terms of infrastructure support, a few key areas that have been supported. At the national level, we have had support to the program in terms of providing laptops, in terms of providing UPS to support the servers at the national program, but also working with the program to see what are some of the needs down at the lower level. That has enabled us to provide data bundles to healthcare workers who are using TIBU Lite to be able to have connection, but also tablets have been provided for access. HIS, we have Kenya Master Health Facility List. These are systems that have been used in the country for a very long time, and at this point in time, sometimes we even forget that somebody has to do the maintenance. We always know that it is always available for us whenever we want to access, and the project is behind maintaining this system. We are happy to report that over a long period of time, there is system availability. The system uptime, I can report that it is at least 95% of the time. If you want to access the reports, if you want to enter any data into KHIS that is reporting at the facility level, the system is always available. The third one, this comes under sub-purpose 2, is capacity building that I mentioned earlier. We have had trainings together with the TB program that has been leading this process. We have trained 41 counties in total, and this is specifically targeting the county TB and leprosy coordinators, as well as the sub-county coordinators, who then cascade this process down to the lower level to see that TIBU Lite is rolled in the facilities. And we have a total of 8,339 healthcare workers as a result of the trainings that have been conducted. What is left at the moment is to be able to train the remaining 6 counties. But then the bigger question for us is, how do we measure the outcome of the work that has been done in capacity building? Looking at the facilities that are using TIBU Lite, looking at the healthcare workers that are using TIBU Lite, but most importantly, is the data getting better as we have more healthcare workers using TIBU Lite? I know that even as we roll out TIBU Lite in more facilities, now that we are almost completing the training, that will be the major question. Is the quality of data improving? Are we able to get this data? Unlike the period when we were using manual tools in the country. The other aspect of capacity building that I want to mention very quickly is the online learning platform that is called the MOH Virtual Academy. Very flexible because you are able to take courses within the online platform at your convenience. There is no registration fee for this, and therefore whatever you need for this is the minimal resources to be able to access the platform. That is internet connection to access the platform. There is certification. Once you have done the courses, you get a certificate for the courses that you have completed. And there is also arrangement to for the healthcare workers to get CPD points for the courses that they have completed for specific regulatory bodies. At the moment, we have 6 of them that are able to provide CPD points. And early last year, there was, we looked at the uptake of courses in MOH Virtual Academy. We have done the same this year, just to be able to find out over this period of time, what are some of the, the changes that have taken place. We have seen growth in terms of those who are enrolling for these courses. We have had more courses added to the online platform. Last year we had 22 courses. This year we have 34 courses. And the number of users that we have this year by January, that was just about 2 months ago, was 13,621 compared to just about half, which was 6,700 last year. The number of daily users, the average daily users was 62 a year ago, and this particular year it has gone up to 150. Specifically for TB, we worked with a program to have the TB guidelines digitized, and this translated into 14 modules in total. And what I have up there is showing the enrollment of users or learners in these 14 modules. We have had a cumulative from early last year when this was completed and digitization of these courses done. We have had 828 learners enrolling for these courses. Out of the 828, we have 263 who have completed the courses. This is translating into 32%. Coming to a close, the other aspect that we have supported is data use for decision making. And I mentioned earlier that Health IT, having been funded by USAID, has supported the performance review meeting. This is the third round of support for the performance review meeting, having started this in 2022. It's a unique opportunity because it brings all the counties together. It brings the stakeholders together and the national team to be able to look at the TB performance. Most importantly, I want us to look at this, that are we improving in terms of the challenges that we have had that have been mentioned over the period that we have had the performance review taking place. We'll be able to see this afternoon some of the improvements that we have had over time. It provides us with an opportunity to ask questions in cases where counties are implementing successfully. It gives us an opportunity to be able to set goals that will guide us to be able to provide effective intervention in TB programming. So I want to challenge us that even as we have been here for the second day, is this performance review meeting making a difference in your county? Is it making a difference even as we provide TB services at the facility level from the various counties where we are coming from? That is just a highlight of the 2023 PRM that we had last year. And finally, in terms of data use for decision making, areas that have been supported previously, we have the TB recording and reporting tools that were reviewed, and this is necessary to be able to reflect some of the changes that we require in terms of the data that we capture, to improve the quality of data that we have, to be able to look at data in terms of, is it able to give us all the information that we have. So that had been done and the tools reviewed. Of course, when this happens and tools that we have in KHIS are also affected, we go ahead as Health IT to be able to revise these tools to reflect the changes that have been done. There is the aspect of DQA, and we need to have, first of all, have an audit of the data that we have. When we have an audit of the data to be able to give us a picture of how the data looks like, we need to then go ahead and find out what are some of the data quality improvement or action plans that you can put in place to address the challenges that we have seen in the data. Are we able to bring out the strengths, the weaknesses, and limitations of the data, and then to what extent can the data be trusted to influence decision-making in TB program. I want us to look at it that when we do DQA, we should have full-fledged process that will make us cycle back to see that the DQA has helped in terms of improving the quality of data that we have, and then how does that translate into improved TB outcomes. So that, in a nutshell, is a highlight of the activities that we have conducted and the achievements that the project has been able to make over the period of implementation. Thank you, and back to you.
Thank you. Thank you so much for that presentation. I know we have been joined here by the Chief of Party for Health IT, Rafael. Karibu sana. I know you will be part of the team that will be responding to question and answer session. So let's appreciate them. Fungua. To abstain ama tufanya gani? Haya. Moja tuende, tusi abstain tuende. All right. Now, it's time for question and answer. I will give an opportunity to like 4 because of time. So, USID TB Act 2, Dr. Sam, kindly, if you can come forward here, and Raphael, for the sake of the Q&A. All right, let me start from this side. Okay. Any other?
Okay, thank you all for the presentations. I have not really a question, but an observation and a way forward that can help us to improve the program. I'm John June, supporting community TB projects by AMREF and Global Fund. The question is on case holding. Our core mandate is case identification and case holding. And case holding we do through management of treatment interruption, support group, and now on that management of treatment interruption, there was a lot of data on the same, and if you look at it, it really impacts on the quality of care that we give. And the tools, this is for health IT. Look at the appointment diary that we use in the TB program. It's like just a notebook with a date, and down there is a comment by the healthcare provider. I think that is not adequate. If you compare that with the other tools that we use in the care and HIV care and treatment, you look at them and they are giving some direction on how to use them. For us, it's at the discretion of the healthcare worker or whoever is filling that appointment diary. Dr. Macharia, you will bear me witness, Sam, you will bear me witness, Ndemo, when we go for OSDV, for you to identify and say that this was a case of treatment interruption or lost follow-up, you have to go through other tools, TB4, TB5, tablet by the CTLCs, and it doesn't help a lot. Can we give priority on that to improve our need? Thank you.
Thank you. That is for health IT. How well can we improve on our M&D tools? Any other? Okay. All right. John?
Thank you. To health IT. So we are trying to upgrade systems in the private facilities under the Global Fund, so selected private facilities. And one of the things we have found when we did the initial, data survey to see what kind of systems are there, we saw a wide range of systems. Every facility is using its own system. And like we have to engage with so many developers, each facilities. So I don't know what would be your suggestion for future to like bring some kind of control and some kind of way that we can have control in terms of TB programming, because what we are doing, we want this system to have a module for TB, but then there are so many, so wide, and we present a lot of challenges.
Okay, thanks, John. This other side from counties. Okay, Malika.
Thank you very much, the team, and the good work is happening. We've been working closely with CHS, but my question goes to Health IT. Over time, we've had a lot of electronic community health information system, and things have been done a lot in that system much. I don't know how we can input Tibulite into that system rather than training them to have another layer of using Tibulite as apart from what they're doing in the itches that is happening to the ground. I don't know how much or how we can move forward towards doing that. Thank you.
Right, fine. Itches integration. I hope I've not left anyone behind. Going once, I think that's fine. So, back to you to respond.
Thank you very much for the questions that you have provided. I will talk about, there was a comment about appointment diary. I think this is a suggestion to be able to look at how this can be improved. I believe that this is taken very positively, and working together with the program, there is always the process of improving the M&E tools. I believe that in the room we have the program, and even going forward we'll liaise with the program to see that what kind of improvement can we do to the M&E tools in general, and specifically looking at the appointment diary that has been mentioned. And of course, this has been a comprehensive process that brings together even the county teams to provide an input into how we can, when review of these tools is taking place, how can we be able to provide, how can we be able to improve on this tool based on the feedback that we are getting from users. That is very well noted. The second question, which I would like to give over to our Chief of Party to be able to respond to, I think is also tied very closely to the third question around systems integration. So I would like to give this to our Chief of Party to respond to that.
Thank you very much, Esbon, and thank you very much, colleagues, for this opportunity to share with you some of the progress that we are collectively making together. I'm happy about the two questions that have been asked. I think we are becoming more aware of multiplicity of systems in our service delivery points and the confusion that that can cause. Indeed, you're right when you say there are many systems in some health facilities. I think the important thing is to understand where we are coming from in terms of these particular systems. When there was a vacuum, people were trying to automate the services or digitalize the services to ensure that we're able to streamline service delivery by streamlining workflows, and that led to multiplicity of systems, and there was no standard way of looking at the characteristics of these particular systems. Now, where are we today? We're at a point where information systems have now been standardized, so there are specific standards that have been developed by the Ministry of Health about the type of information systems that we should be developing and deploying in our health facilities. And those particular standards have also come with a number of support elements, including the certification framework. I think what we need to do is to share as widely as possible these particular certification frameworks to be able to identify what kind of systems would qualify to be deployed in the health facility. What the Ministry of Health is saying, especially the Directorate of Health Informatics Policy and Research, is that they do not want to stifle innovation, and therefore they will allow different actors to be able to have information systems, so long as those information systems adhere to standards and have been certified. And one important development that we are seeing, and I think we are going to see very soon, is the introduction of the Digital Health Agency, which is going to be a body that will be authorized by law to be able to manage the information, the digital health ecosystem in the country, and one of their tasks is going to be information system certification. But beyond that, at a technical level, the Ministry of Health has also set up what we call the Health Information Exchange, which they are now referring to as the Information Superhighway. And this particular information exchange architecture involves tools, involves registries, involves information systems, involves repositories that are necessary for different information systems to be able to exchange data. And I think you have seen discussions, not that discussions, but implementations on what we call the Kenya National Health Terminology Services. We have seen the client registry. Of course, we know about the Kenya Master Health Facility list, and there are a few more registries that are being developed to enable interoperability to happen. To finalize on that, the Ministry of Health has identified 3 major systems that have met minimum standards that could be deployed in the health facilities. One of these is the Afya KE. I think this has been deployed somewhere in Murang'a. Then there is Tibabu. So Tibabu is a system that was used to activate the primary healthcare network in Kericho County. And we also have the integrated Kenya EMR, which brings together the CCC modules and the facility-wide modules. And all these 3 systems are interoperable through the Health Information Exchange, and they create what we call a shared health record. Shared health record is a record that you can take to any facility, and they'll be able to look at the minimum records that will help the service provider to provide you with the necessary services. So it's a long answer, but I think it was important that I provide that background because the future looks like we are going to have standards-based interoperable information systems in our health facilities and in our community units. As you are all aware, ICHIS version 2 is the one that is widely implemented, but we know that ICHIS version 1 exists in some counties, probably about 1 or 2 counties in the country. There's a good question about the interoperability between Tibulite and ICHIS. And indeed, this is an important question. I think it came up when we had a meeting, the meeting with the other cluster earlier this week. This is an important one, and I think the possibilities are there. Tibulite has been developed with the capability to exchange data with a very strong web application programming interfaces that allows it to exchange data with other systems. Similarly, the other systems that we have at the facility level have got this capability as well and are compatible with the data exchange standards like the Fast Health interoperability resource that we are using to activate interoperability in the country. So working with the program, specifically the M&E team, will start from here and find ways in which we can quickly be able to deploy the data exchange between Tibulite and the rest of the facilities, the rest of the systems in the facility, but specifically target ICHIS because of the nature of tuberculosis being mostly traced at the community level. So thank you very much. I think I take it back to Hesbon.
Yes, Hesbon and Raphael, allow me to hijack the conversation a bit. So I want to speak to what Juna has asked in terms of treatment interrupters. And my opening statement is sometimes, and having worked in the TB program and the HIV program, sometimes I find the comparison a bit, in quotes, a bit unfair because we, in the TB program, have very robust innovations that the other divide can also learn from. But I also appreciate that there are lessons we can borrow from them. And I want to bring out this aspect of, for example, the appointment diary. The appointment diary is a handwritten, hard copy approach to managing appointments. And yes, I know there can be improvements that we can have in making it better. However, there are now better solutions that we can think about and see how to scale up. And one of them is digital adherence technology. Here it offers us a platform for differentiated care. And here is what I mean when I say differentiated care. You will have treatment interrupters who have different needs. There's this busy person who has to travel. They have not exactly missed their medication, but they are traveling. They have just not come to see you. If you use a diary, you would be stuck. You would need to understand their context to be able to support them. You can have a treatment interrupter who is a nomad. And now we are speaking about, for example, wet borders, or we are speaking about cross borders. People who have to travel because of their subsistence needs. And because of that, there is an impression created that they have interrupted treatment, but it's just that they are moving. How do you respond to that? So with digital adherence technology, one thing we learned is that you are able to fashion the adherence needs to a particular patient, and also further still use different modalities per patient. So for example, there is that person who just needs an SMS reminder for them to keep an appointment. They don't need anything else. There's that person who needs to come to their facility and speak to you because they have challenges, for example, in their household. That's a category of treatment interrupters. There's another one who will need a pill box. They are moving with their cows somewhere, for example, and the pill box will send you a message that, hey, it's been opened, this person has taken medication. So my point is that I'm pushing us into a frontier of more responsiveness and more technology-driven approaches in addressing the issue of treatment interrupters. And to sum it up all, that these approaches also foster a patient-centered approach between the healthcare provider and the patient, so that you're able to discuss some things. Discuss what is the context of your treatment interruption? How can we support you better? As opposed to the previous models where we would say, you are a treatment interrupter. You did not come, and we have noted that you missed this in your diary. Hii kitu si mzuri sana. You know, that's a top-down, talk-at, non-supportive approach to helping that particular patient. So I'm looking at this frontier as a place where we need to go as a TB program in handling our treatment interrupters, and other programs, including HIV, probably would be able to learn from us. Thank you.
Thank you, Daktari, for providing insights into that. And I believe that the approach of digital health adherence is a very in-time comment to be able to address the challenges that are there in terms of using appointment diary or making improvements on that to address treatment interruption. I think we have been able to address all the questions. Back to Dennis.
Thank you so much. I believe that was comprehensive. I hope all who had the concerns have been answered. So I want us to appreciate them as we close this session and get to another section. So let's stand as we do an energizer and as we plan to go to the next. Aya, DJ, ngoja kidogo. All right. First of all, Let's appreciate them, then we do an energizer. Sawa? Since Dr. Sam is part of the team, and he always has a slogan that is always known with everyone. Si tunaijua? Like? Very good. So, we want to appreciate them. Na ile ya, like a mouth of a hippo. If I say, like the mouth of a hippo, and you unatoa sauti, mi najua mjakula, lakini try to have the energy. Sawa? So if I say like the mouth of a hippo, sauti haitoki side. Like the mouth of a hippo, like the mouth of a hippo, snap it, snap it, like the mouth of a hippo. Mi unataka nisikie ile. Yeah. Hippo unajua haya kuna soprano. Haya, lakini nataka ile like itoke kabisa vile hippo inaweza snap. Ukirushia watermelon. Eh? All right. All right. Like the mouth of a hippo. Ha. Like the mouth of a hippo. Snap it. Again. Snap it. Thank you so much, team. Okay. Sijasema mketi. Tulikuwa tufanye energizer. As you set up, let's do an energizer for the next session. So nataka tufanye ka energizer. Tafuta ka space. A very good space. Kama mmekaribiana sana, unasonga kando kidogo. It's a 5-second energizer. 5 seconds. So siwasumbui sana. So kindly kama umeketi amka tu. Kozini ya kusonga. You have to move. Right? So you have to move. Hii energizer hakuna kusema, oh, kama ulikuwa mmependana hapo karibu karibu. Get your space. All right. 1 second. DJ, let's go. I want us to do something. You just clap as you move. Sawa. You clap as you move. We want to do something called clap snap. Go with the beats. People are not moving. Clap. Harder. Iko watu wasonge bana. Ni nini? Clap. Everybody dance to the music. Very good, very good. Hi. Thank you. Ama nimemaliza energy levels. Okay. So now, if you look at the program, we are almost done. So we want to go to the section of the scorecards. So we have a county scorecard that is coming up in the next 20 minutes. Then after that, now we will go to the county scorecards. So let's give him an opportunity to share with us what he has in the next 10 minutes or 15.
So good afternoon, everyone. My name is Maurice Maina, and I'm an SCTLC from Nairobi, Embakasi. I'm part of the leadership from the sub-county TB coordinators. These are a correction or an analysis done by some of the CTLCs and some of the SCTLCs of the activities that the national program are rolling out in the counties. This is how we shall be going through. That is the outline. This journey started sometimes last year. That was our first presentation when the idea came about, and then we came together, both leaderships of the sub-counties and the county. We came up with a tool. We were able to go through the scoring processes, and I'll be presenting to you the findings of what we were able to correct. So we were able to assess the various sections in the program. That is care and support, diagnostic services, HPT, prevention, administration, finance, policy and planning, and of course, M&E. The only section that we also added as part of that is a capacity building component, which cuts across all the other sections. In the various areas for the care and treatment, we were focusing on the quality of support, and especially for TAs, especially for visits that they do to the counties, about communication, looking at involvement of counties and sub-county coordinators, and especially PIA on looking at ACF activities. On diagnostic services, majorly we were looking at diagnostic equipment availability, as well as also TATs for the various resorts supported by the program, as well as also the partners. These include the Culture Resorts, the LPA, Lancet Resorts, and of course, Sputum networking. On supply chain management, this focusing on health products and technology. We're looking at availability of the various commodities, that is the patient packs, the loose formulations for all HZE, DLTB commodities, Gene Expert, HIV testing, as well as also other complementary medicines, including nutrition and pyridoxine. On matters prevention and community engagement, we looked at the various activities happening in the community. Some of the activities also that are being carried out together with our partners, supported by the National TB program, in regards to prevention and engagement of the community health strategy. And of course, looking at this, focusing our efforts on how we are partnering with the rollout of primary health care and UHC in matters of community TB. Capacity building, as I have indicated, this one cuts across on all the program sections, and we were looking at some of the trainings that have been rolled out and the feeling of the counties in the rollout of those activities and how they felt that they were supported on capacity building. Administration, finance, and equipment management. Basically, this was looking at claims reimbursement for supervisions, DLTB, patient support and timeliness, reimbursement, zoning, motorbikes, repairs, and also DLTB meeting support. On policy planning, of course, this one dealing with the rolling out of the national strategic plan, work plans, guidelines, any policies or SOPs that have been shared with the counties. And the last one was M&E. Of course, this one also is the backbone of most of the activities that we are carrying out, looking at involvement of the county teams in research, support on operational researches on the data that they collect, involvement and support to attend long conferences, especially for those with abstracts, quality of the tools also being given to the counties about TB issues, and sharing of listings of transfer outs and loss to follow up to improve the quality of the data that we have. So these are the findings. Where you see a red means it's fair. They felt that we were not very well supported. Where you see a yellow or an orange is good, and the excellent is the green part. We engaged all the counties. However, we were not able to get responses from all the counties. We only got responses from 40 counties. And out of the 40 counties, we got 163 respondents responding to the findings. So this, about care and treatment, over 90% of the respondents felt that they are aware that counties were supported to do TA's mission, and this is both for the counties and sub-counties. Only a few, that is less than 10%, felt that they were not aware that TAs were conducted. On distribution of the TAs in the counties and sub-counties, a good number felt that they were visited and they were supported with their activities, especially on technical assistant missions, and only 25% felt that they were not visited and they were not supported, or they didn't get any visits from the National TB program and its partners. On matters quality of the TA's mission conducted, a good number of the people that responded felt that they were having a good learning opportunity, that is at 63%. 23% felt there was a good exchange of ideas, best practices, and there was a good learning opportunity. And only 15% felt that there were aspects of fault finding, aspects of victimization, and sometimes they were uncomfortable. And of course, this is an area that we feel needs to be improved on so that at least 100% of the people that were visited feel supported. About the quality of communication in regards to timeliness and leadiness, you will see that 49% felt they were well prepared, that 3% got a communication prior to the visit, and 23% felt that there was some form of an ambush or they were not well prepared that they are going to be visited. And probably this is an area that we can still work on. About involvement of the county teams in TA's mission, the 66% of the of CTLCs, that is the county TB coordinators, felt that they were involved, and they were also part of the teams that were visiting the counties. And only a few, that 4%, felt they were not involved or they were not participating in the TA's mission to their counterparts counties. For the SCTLCs, the graph changes hands. 74% felt they were not involved or they were not part of the team that were visiting the counties, and 26% felt or expressed that they were involved, they were part of the teams that were visiting the counties and participated in the learning opportunities in that section. Down to different activities. One of the activities we assessed was active case finding activities. And remember, this one we are actually looking at what the program is doing as well as also the partners that are supporting. Some of the activities that were well supported include community TB activities, targeted TB screening, contact tracing, conducting of mobile clinics and outreaches, integration with other programs in matters of screening, and of course all the way to screening in workplaces and prison centers. So we feel at least community-based activities, the counties feel they are supported through the program and the various partners supporting the same. On TPT activities, these also scored quite fairly or very well. In matters of TPT, preventive therapy, availability, targeted household TB screening, healthcare workers training on TPT, community involvement and engagement, and this one we were looking at whether some of the CHPs or the community strategy section has been involved in rollout of TPT, and some of the respondents felt they were supported, all the way to policy, advocacy, and implementation, and all these are matters that the counties felt that they were supported. On matters PPM, engagement of the private healthcare providers is well supported, and training and capacity building of the private healthcare providers was also very well supported. Diagnosis, sputum networking, standardization of treatment protocols, referral systems, and partnerships, all that was really well supported, and as you can see, scored quite well. About feedback in matters DLTB, when we share case scenarios or when we share DLTB cases, good number, 59%, felt they were getting good responses and on time. 24% expressed that there was an excellent support on the same, and only 17% felt that there needs some improvement on timeliness, especially on feedback on the cases supported. On capacity building activities, trainings and workshops, we were looking at different areas that were involved there, including TA's missions, and about TA's mission, monitoring and evaluation programs, PQ mentorship, leadership trainings, and policy. And it is important to note that pediatrics TB, I think we carried out quite a number of trainings, and most of the respondents expressed the same. TPT was also part of it, all the way to TB nutrition, which only seven respondents expressed that they were participating in that. About the feeling on structure of the training and the rollout, 90% felt they did not agree or they were not comfortable with the way it was being rolled out, and almost 80%, that is expressed that they agree or somewhat agree with the way the training structure was being rolled out. On diagnostic services, and these including consistency assessment and testing and infrastructure, you realize that most of the areas are not scoring very well. That is the green component. On about the cartridges, about the availability of the machines, distribution of the same, card X-ray, TAT for the results, TAT for the LPA, and sample transportation scoring quite high. That is at around 66%. I think that was quite well. The hardest hit area was the commodity section, and this is because of the outages of the commodities. The respondent felt that there was a good area that needed some improvement, with an exemption of the DLTB commodities, which showed that there is timely distribution. About consistency assessment, reporting tools availability, most of the areas scored quite well. As you can see, most of the registers were quite available, and especially the CML, TB4 register availability was also there. The only thing that was missing out were the patient appointment cards, the small cards, and the patient record cards, quite high, as well as also presumptive registers. About M&E, research and learning, county teams support to do researches, operation researches. Those are the areas I think we need to work on that, so that they can be field supported. And the ones that have abstract express that they are not receiving very good support on the same, both for the CTLCs and SCTLCs. Involvement also of the county teams in rolling out of tools or development of tools to ensure quality. Also, that's an area that we need to look at. An area that scored quite high is about the tablet and TB issues handling, listing of sharing of the TO's risk, loss to follow-up listing, and also involvement in DQIF forums. On policy planning and availability, this including applicability, sharing of the national work plan, NSPs, as well as also adherence to the same, stakeholder involvement. That is how the scores were. And probably this is an area that we need to improve on. On matters, prevention, health promotion, and community engagement, most of the areas scored quite highly due to the various supports that we have in the counties with the support from our partners and then NTP. On administration, finance, and equipment management, supervision claims reimbursement, I think scored quite highly. We all can guess that one would still score highly even in the coming one. And the other areas that also were looking at timeliness on DLTB patient support, not very good. And also tablet distribution is also was an area that needed some support. Motorbikes repairs and reimbursement also was an area that we needed some support. On average, all on areas that we were scoring, on capacity building, administration, finance, care and support, prevention, and community engagement scored 0.5 each out of a perfect score of 1, giving us an average of 0.5. As you can see, we really improved comparing to what we were able to do last year. We have improved on that. We were actually on the section of the not optimized. And some of the areas that we were looking at, or some of the summaries of the areas that on the comment section that we were getting about commodities, some support, transport reimbursement, TAs, and all that. Lastly, I would like to appreciate the forum for the support that they have had to us. Thank you so much.
Thank you, thank you. Si tupanue kwanza, tupanue kabisa, turembeshe kabisa, turembeshe tena, angusha. Okay, I think hatuna swali. So we want to appeal one thing. This time we want to change a bit of the program kidogo. We want to finish everything, then we go for lunch and then we disperse. Are we in agreement? Unajua hii democracy ni kali sana. Unataka tufanye hivyo, sivyo? Sawa sawa. So as Martin said in, DJ, you can watu wasimame kidogo, Please kindly, I'm just looking kindly. Situfunge laptop tafadhali. So Martin, you can go to the stage as wakiji. Make. Yes. Sawa sawa, tuimbe sasa kindly. Si watu waimbe sasa. Tomno funza vile hii kitu nyimbo inaimba. DJ endelea tu paka watu wasimame waimbe. Martin, saizi si ni very enjoyable because mnaangalia scorecard, sivyo? Situfunge tu laptop tuangalie scorecard. What was the progress mlifanya for the last 1 year? Si hata program tumefanyiwa. Sasa wacha tufanye account tuone how things are moving, sivyo? So Martin, welcome. Continue.
Good afternoon, everyone. Good afternoon. Yeah, I know I'm also nervous, but don't stop yourselves from saying good afternoon. But just like the previous years, we are just going to walk through our performance in terms of the performance scorecard. And of course, one thing we wanted to highlight this year is that this is the 5th year we are doing the scorecard. And of course, in all the scorecards we've done, we've had new winners and new losers for the 4 years. So I don't know if this year is going to be any different, but the other aspect that we also need to be aware of is that we are looking at data as of 16th January. So if you made changes to your data, if you cleaned, fixed a few things, most likely it will not reflect in the scorecard because there's an aspect of timeliness that we are also checking. So please note those two things. But of course, the criteria did not change so much. We stuck to the 4 areas we're looking at, that is data, quality of care, lab, and a few extras. And I will just get straight into the data aspects. Of course, there are things that were already discussed in the earlier presentations, so I'm not going to repeat them as much. But just to point out that accuracy as an indicator in our data actually dropped last year, which is a big issue for us. Secondly, the other indicators like completeness and timeliness marginally improved. So we still have a long journey to go in terms of data quality, looking at the aspects that the scorecard was trying to measure. However, results from the DQA show that there's a lot of improvement in terms of what is at the facility level and what we get in our national surveillance systems. So this is something positive. Then on availability of tools, we noticed that there's a 93% chance that you will get M&E tools in the facilities. But of course, we also acknowledge the findings from the sub-county and county scorecard that M&E tools were flagged out as an issue. So we need to get to the bottom of it. However, for level of agreement among the bacteriologically confirmed cases also improved. TPT data also improved marginally as per the DQA that was done last year. So there are a number of issues that we look at in the data. And like I told you last year and probably the year before, we just analyze the data you have, then rank you with the others. We do not introduce new things. We do not probably want to change a few things here and there. We just look at what you have. So the scorecard is more or less your product, only that we are the mouthpiece of it. And we also don't look at sub-county data, then calculate an average and end up with a county score. No, we score each data set independently, including the national data set. So even for the national data set, there is no picking performance from the counties and assuming that's the national performance. So you will be seeing that as we go along. And on some indicators, you will notice we are scoring county only. In others, we are scoring county and sub-county. So data accuracy, data completeness, we looked at quite a number of things in the DSTB data, smear completion and timely outcomes. And you can see in both areas the country somehow improved, which is something positive. So it means that at least we are making some efforts in terms of ensuring we have quality data. Timely notification, are we entering data on time? So on that also the country improved slightly. And also ensuring completeness in BMI evaluation, you can see there's also a good improvement on that area. And it is our hope that we can start scoring perfect scores on these indicators. Then ensuring case accountability, now this is completeness. The country dropped on this, so it means as compared to last year, we had some records that didn't have outcomes, so we didn't quite score very well. And of course, accuracy, ensuring that every record has a valid outcome. And you can see we improved on that, especially for the cured who are clinically diagnosed and also cured that were extrapulmonary. So those are the things that we were looking at. And you can see on both areas we had some improvement. Accuracy in documenting BMI, you can see we maintained what we scored last year. So it means we probably didn't have any major change in this particular indicator. But of course, based on what the scorecard from the county and the sub-counties showed, there is a challenge with anthropometric tools. So that could probably be the reason why we are not scoring very well in that particular area. Then for DRTB, looking at timely outcomes with a threshold of 720 days, you can see the country dropped on this. So yes, we have improved DRTB TSR, but we are not assigning outcomes on time. We have moved from 81% to 83%, but that data is not being updated on time. So that's what this is showing us, and it seems to be getting worse every year. There's delays in updating DRTB outcomes. Smear completion for DRTB, you can see also this dropped from what we had last year to 0.56. So this is also a challenge, and I think this is within the control of the facilities and the sub-county teams. So this is something all of us will probably need to look at. Then ensuring updates for culture, also a huge problem. And I also want to admit that I saw the TAT being raised by the county and sub-county scorecard towards the national program, TAT with culture and LPA results. So those are things that probably contributed to this poor result, but we need to see how best to improve it moving forward. Then regiments, we didn't score it last year, but this year we managed to score 3. So there is a good baseline for this, and we need to build on it, ensuring that all the RTB clients have the correct regiments. Then assigning outcomes, this is just about case accountability, and it's an aspect of completeness, ensuring that every record has an outcome. And you can see we dropped on this. So it means if we had probably looked at all our records and ensured that the DRTB clients have outcomes, probably the indicators we've seen in IBAN's presentation earlier would probably even been better, but some records were left without outcomes. So we start looking at all those things I've mentioned and looking at where the counties featured in terms of the scores. And for timeliness, this is an aspect that we measure both for the county and the sub-county. Third best was Mombasa County, moving from rank 15 to rank 3. Second best was Siaya, moving from rank 19 to rank 2. And the best was Migori, moving from rank 22 to rank 1. So all these counties are here. They did very well in aspects of timeliness. So if we are starting to take stock of our progress, these counties are already ahead. I'm not saying there's anyone who is at 0, but these guys are ahead already based on that particular step. But now what is not really a happy situation for us is that counties that feature as the best in this particular area, next year completely disappear. So it looks like when we go and sort out other issues, we compromise the data quality in a way. So Machakos County was ranked best previously. Right now they are nowhere to be seen. So you can see why I'm raising that point of you are here today, next year you're not here. Then completeness also ranked county and sub-county. And third best was Kitui County, moving from rank 5. Samburu County was second best, moving from rank 42. And the best was Murang'a County, moving from rank 12. And previously, this was something that Kwale did very well in terms of completeness, but right now they're also nowhere to be seen. So that's an issue with data that you will also notice as we move along. In accuracy, third best was Mandera County, moving from rank 28. Second best was Elgeyo Marakwet, maintaining their rank. Now this was unique, and in the previous cluster we really appreciated this, that they maintained some milestones that they achieved last year. And the best was Lamu County, moving from rank 11. So on those aspects of data, next year we'll probably come up with a different award for best in data quality, because we've noticed it's becoming a moving target. People are not consistent with data quality. So next year probably there'll be an award just for best in data quality, looking at all those three aspects I've mentioned. Now in quality of care, just worth mentioning is that the country improved in terms of treatment success rate from 86 to 88%. And I know in all our documentation and in the NSP, our target is 90. But for the purposes of the performance review, and this is something all counties in this room agreed to, we are looking at 92% as a target. So we'll be scoring based on that. So for the performance trends, I will also not take so much time on this particular slide, but it's just highlighting what was in IBAN's presentation about our outcomes. However, you'll notice that 2 unfavorable outcomes maintained the same proportion. That is loss to follow-up and death rate, which is not really good. We had hoped probably would reduce on loss to follow-up or death rate. So what that means is, yes, we have increased our treatment success rate, but it's not as a result of reducing these 2 unfavorable outcomes. So you might need to contemplate on that as we move along. But the other things in this slide were already mentioned by IBAN. So for DRTB, I thought this is also worth mentioning, that we had a 7.1% case drop, but of course TSR improved, and death as an unfavorable outcome also marginally declined. So there are 2 positive things, but the drop in cases is something concerning, considering also DR surveillance has not yet reached the perfect level that the country would want. So let's now break these quality of care indicators one by one while looking at how counties performed. And of course, some will have county and sub-county, as you'll notice in my title. The first was private sector performance with a proportionate hit or miss target of 25. By proportionate hit or miss, I mean you get that proportion to score. If you don't get the proportion, you get 0. So counties that did well here were Migori, Garissa, and Kisumu County. So as we go along, you're noticing Migori is becoming a problem, yeah? They are scoring all over the place. Next is nutrition. This was assigned a distributed weight, and distributed by patient means we looked at clients who are eligible for food support. Were they offered food support? If yes, we scored 2. If they were not offered food support, we scored 0, then calculated the mean as the final score. And here, 2 counties retained their ranking, that is Homa Bay and Mandera, marginally increasing their scores, but Murang'a County now joined this group. It wasn't in this group before. So for Homa Bay and Mandera, you will need to have a side discussion with people and tell them where you are getting this food. You have maintained this for 3 years, and others are struggling, so you will tell us how that is happening. Then for DR surveillance, among new patients, also assigned a distributed weight per patient, so it means we looked at all new patients. If DR surveillance was done, we scored 4. If it wasn't done, we scored 0, calculated the mean as the final score. And you can see the country slightly improved on that. Third best was Meru County. Second best was Nandi County. And the best was Marsabit County. So for Meru County, I think this is something huge for you, considering you also have a high DRTB workload. So it could explain why you have a high DRTB workload. But for the other counties, I think this was a new achievement for them. And I think this is something that can be maintained moving forward. Now, looking at the same among previously treated patients, we assigned a distributed weight of 5 per patient, which also means if it is a previously treated patient, was their surveillance done? If it was done, we scored 5. It wasn't done, we scored 0, calculated the mean as the final score. And here, third best was Laikipia County. Second was Homa Bay. The best was Kwale. So on this, when I mentioned 5, please note that 5 is a heavyweight. So if you score favorably in a 5, you're most likely ahead of so many other counties. Then we moved to DSTB case notification. So we were looking at who increased case finding, and this is assigned a proportionate distributed weight. Remember I talked about proportionate hit or miss. Now we have a proportionate distributed weight, where we are assigning a distributed weight by proportion. If you increased your case finding over 20%, we scored 4. 10 to 19.9%, we scored 3. 5 to 9.9%, we scored 2. 1 to 4.9%, we scored 1. Anything else, we scored 0, including those who dropped. You can see the country dropped because last year we had an increase of 16%, and this year we have an increase of 6%. So counties that did well here were Laikipia, Narok, and Nyamira, who scored the perfect score of 4. Next is pediatric notification, also assigned a proportionate distributed weight, looking at the proportion. And of course, counties had a target of 15. Counties that did well here were Turkana and Embu, and I think this was well highlighted in the presentation that Iban did. These are the counties that scored a perfect 4. Then the most troubling hit or miss weight. Now this is a proportionate hit or miss weight for DSTB TSR with a target of 92. So for all of you who are here, you know if you scored here or you didn't, based on the presentations you did. But there are counties that have maintained their space here, like Laikipia, Kisii, Homa Bay, Migori, Mandera, Siaya, Wajir, Nyamira, Lamu, and Garissa. So Garissa wasn't here last time, but now they have joined the group. Then there is Kwale, Marsabit, and Tana River. So the ones below have also joined the group. Now, something beautiful about this slide is every year it gets busier. I have to make space for more counties. At some point, I'll have to convert this into 2 slides if we continue having counties joining this group. So that is something positive, and probably that is why the country also improved in the TSR. And then we introduced a new indicator which looks at TSR among transfer inpatients. So if you had the courage to manage transfer inpatients very well, we assigned it a distributed weight of 3, and it's a proportionate distributed weight, which means anything above 90%, you score 3, 80 to 90, you score 2, 70 to 80, you score 1, anything else, we scored 0. So counties that did well here are quite a number, that is 26 counties. And I was told, I think last year, that I have to mention all these names because you might not be mentioned anywhere else. So let me just do that. So Baringo, Bomet, Bungoma, Elgeyo Marakwet, Embu, Garissa, Homa Bay, Kakamega, Kilifi, Kitui, Kwale, Laikipia, Lamu, Machakos, Makueni, Marsabit, Migori, Nakuru, Narok, Nyamira, Samburu, Siaya, Tana River, Tharaka Nithi, Uasin Gishu, and Wajir. They scored the maximum weight here, which is 3. And this is a new area. So if you have not mentioned it, means you most likely scored a distributed part of it, or maybe even 0. Then there is DRTB TSR, another hard indicator, 92%, proportionate hit or miss. And counties that did well here were 24 counties, scored a perfect 5. Bomet, Busia, Embu, Homa Bay, Isiolo, Kiambu, Kilifi, Kisumu, Kwale, Laikipia, Lamu, Mandera, Meru, Migori, Mombasa, Nakuru, Nyamira, Nyandarua, Nyeri, Siaya, Taita Taveta, Tana River, Tharaka Nithi, and Trans Nzoia. Then next is cure rate, another tough indicator, assigned a proportionate hit or miss of 5. Counties that scored a perfect 5 here were Nyamira, Laikipia, Kisii, Homa Bay, Makueni, Mandera, Wajir, Kitui, Migori, and Siaya County. So in this particular performance, there are counties that we flagged out to also have other issues which were somehow not very comforting. That's Nyamira, Homa Bay, and Siaya. Their proportion of bacteriologically confirmed cases is very low. It is actually the lowest in the country. So it makes this indicator easier to achieve. So that's a concern, and probably in the subsequent scorecards, we are going to penalize that. If cure rate is so easy to achieve because you have a very small cohort, then we are going to take off something. And actually, as we go along, you'll see one slide already targets that particular trend in the data where somebody has very low bacteriologically confirmed proportion, then they do very well in cure rate. DR cure rate, proportionate hit or miss of 5. Counties that did well were Busia, Homa Bay, Kwale, Laikipia, Lamu, Mandera, Siaya, and Taita Taveta, and Tharaka Nithi. Then next is TPT completion. As you're aware, previously we didn't quite score this because there were issues with data, which we have since resolved. But we looked at the ratio of 1 to 3, 1 bacteriologically confirmed having 3 contacts line listed and investigated. So here we have Nyamira, Tana River, and Vihiga scoring 3. And the others, it's a distributed weight. The others scored something, but not a perfect 3. Then HIV testing, we changed this. It was previously a hit or miss of 100, but now we've distributed the weight, proportionate distribution, only favoring those who have 95% and above. If you have 95% and above, you score 2, but if you had 100%, you score 3. Anybody else scored 0. So here counties that did well were 6 counties: Elgeyo Marakwet, Kirinyaga, Kwale, Lamu, Mandera, Nyandarua. Then ART uptake, this year we did not score ART uptake because while looking at the data before the DQI that we had in January, we noticed the ART variable had an issue. So it would have been a disadvantage to most of us if we had scored it. So we didn't score it for everyone in the scorecard. So if this was your strength, we apologize. We have missed out on this. But next year we'll be scoring it again. Then low death rate, maintaining a low death rate. So this is a proportionate hit or miss. It's a proportionate distribution. If you had 5% and below, you score perfect 5. 5 to 6, you score 3. 6 to 7.5, you score 1. Others scored 0. So we did this recognizing that we cannot attribute all deaths in the TB register to TB. This is why we distributed the weight. And of course, counties that did well here were 20 counties. That is Baringo, Bomet, Garissa, Homa Bay, Isiolo, Kwale, Laikipia, Lamu, Mandera, Marsabit, Migori, Mombasa, Narok, Nyamira, Nyandarua, Pokot, Tana River, Tharaka Nithi, and Wajir. Okay? So if I've not mentioned your county, tunakaribia kumaliza. So you should be concerned. Then next is DRTB death rate, maintaining a proportion of less than 5, but this is also distributed just like the previous one. Counties that did well were 18 counties: Bungoma, Embu, Homa Bay, Isiolo, Kilifi, Kisii, Kisumu, Kwale, Laikipia, Lamu, Mandera, Marsabit, Meru, Mombasa, Nyeri, Taita Taveta, Tana River, and Uasin Gishu. Then low loss to follow-up rate. So this one was assigned a proportionate hit or miss of less than 2%. 13 counties did well. And please note that the weights I'm mentioning now are heavy weights. So if you are consistently missing, now you're being left behind completely. So these are 5, 5, 5. I'm now mentioning the 5s. Here we have Garissa, Homa Bay, Isiolo, Kisumu, Laikipia, Lamu, Makueni, Mandera, Migori, Nyamira, Siaya, Tharaka Nithi, and Wajir. Then low loss to follow-up rate among DRTB clients. We had 31 counties scoring 5. So for this, I didn't list. There were too many. So if this is the only place probably you scored well, I am sorry. I will not mention, but just know that when you see the report, you will get to see you scored there. Then increasing DRTB case notification. Please note that nationally we are below the target by far, so this is why this is being scored for those that actually made an effort and increased DRTB case finding. 14 counties scored 4: Isiolo, Tharaka Nithi, Bungoma, Kilifi, Uasin Gishu, Meru, Nyeri, Vihiga, Murang'a, Taita Taveta, Kwale, Baringo, Tana River, and Kajiado. So that sums up the quality of care, and most of the scores have been achieved there. But as we go along, you'll notice something different with the scorecard this year, which also surprised some of us. We have not seen happen before, so I think we'll just highlight that when we get to it. On diagnostics, we are still scoring Gene Expert performance, and you can see nationally we improved to 90% as per the earlier presentations. And the indicators and weight for Gene Expert has not changed. Where an email is sent for every test, we score 3. Where it's not sent, we score 0. Calculate the mean as the final score. Same thing with the SMS, but the SMS now is a heavyweight of 5 because this is a crucial thing for us. So if SMSs went out, you score 5. If they didn't, you score 0, and we calculated the mean as the final score. Error rate, this was hit or miss, assigned a weight of 3. So if your error rate is above 4%, you most likely missed out on this. And there is no negotiating that you got an error rate of 4.1. So we should have that kind of, oh, nipatie kidogo. This one is hit or miss. Then there is expert utilization. So we took what you have documented as your expert utilization, subjected it to the weight of 5, and that was your score. So if you had an expert utilization of 90%, you can calculate that yourself and see how many, what weight you scored here. Then online, offline processing, we looked at all the tests that were done. Those that were done online scored 5. Those that were done offline scored 0. We calculated the mean as the final score. So that sums it up for Gene Expert, giving us a total weight of 21. And you can see the country really improved on this from 10 to 15. So we are nearing that picture where we have very good diagnostic data for Gene Expert. And we hope when we bring in the new tools, we are also going to maintain that level of data quality. So counties that did well here were Murang'a County scoring 18, Siaya County scoring 18.2, and Vihiga County scoring 19.6. So on this, every county actually scored, and the margins were very small. I think there's been a lot of improvement with the Gene Expert utilization and management. And of course, as you notice from the title, on this we only scored the county because we recognize some sub-counties don't have Gene Expert machines. And here we also appreciated Nairobi in the previous cluster, moving their weights from 7.6 to 15.93. This is something they deliberately worked on after realizing this was a challenge with their performance, and you can see when their ranking improved on that. So we move to the extras. So extras majorly look at commodity issues, ACF cascade, and of course the bacteriologically confirmed issue I talked about earlier. So we have timeliness in commodity reporting, and I have seen this being presented in the various groups. We assigned it a proportionate hit or miss of 95. And since Kenya was above 95, we scored 5 on this. And 14 counties also scored 5: Bomet, Bungoma, Embu, Homa Bay, Kakamega, Kericho, Kilifi, Kirinyaga, Marsabit, Migori, Mombasa, Nyamira, Siaya, and Uasin Gishu. Then next we looked at was ACF reporting, assigned it a proportionate distributed weight. We compared KHIS data and TIBU data, looking at proportion of the KHIS RTI data that was screened. Anything above 60 scored 3, above 40 scored 2, above 20 scored 1, others scored 0. Counties that did well here were Laikipia, Murang'a, Nakuru, Nyamira, and Nyandarua. Then sample rejection rate from not just NTRL, but also Kisian. This year we also included Kisian data. So those that sent samples to Kisian, probably they were being rejected and you were escaping this scoring. Right now we have also incorporated that. And you can see the country scored favorably on this. This is a proportionate distribution of weights. And 41 counties scored 5. However, 2 counties scored 0. That is Garissa and Marsabit. So in the other slides I've been mentioning people have been doing well, but on this I took a different approach. I'm mentioning the ones that scored 0, where everyone was scoring 5. So these 2 counties probably, as you're computing your scores, tayari mmeachwa nyuma. Then proportion of pulmonary TB that are bacteriologically confirmed. So this has been there, but we are going to strengthen it because of what we noticed in the cure rate. 5 counties scored 2, Kitui, Marsabit, Meru, Nandi, and Pokot, means they had at least 60% of their pulmonary TB cases being bacteriologically confirmed. So we are only focusing on pulmonary, not the entire case finding. And of course, when we looked at the entire case finding, Siaya, Nyamira, and Homa Bay had very low proportions of bacteriologically confirmed cases. Then reporting rates. Now we looked at timeliness. Now we are looking at whether we got a report or not. Assigned a hit or miss of 95%. The weight is 5. Counties that scored 5 were Bomet, Bungoma, Embu, Homa Bay, Kajiado, Kakamega, Kericho, Kiambu, Kilifi, Kirinyaga, Kisumu, Kitui, Laikipia, Marsabit, Meru, Migori, Mombasa, Murang'a, Nairobi, Nandi, Narok, Nyamira, Pokot, Samburu, Siaya, Trans Nzoia, Uasin Gishu, Vihiga, and Wajir. And take note that these extras, most of the extras, we are only scoring the county. We are not scoring the sub-counties. Then looking at the ACF cascade based on data that is in TIBU, among those that were diagnosed in the ACF cascade, how many were started on treatment? And of course, the weight of 3 was distributed as is described up there. Counties that scored 3 was Baringo, Bomet, Embu, Garissa, Homa Bay, Kiambu, Laikipia, Lamu, Mandera, Marsabit, Meru, Migori, Mombasa, Murang'a, Nandi, Narok, Nyamira, Nyandarua, Pokot, Siaya, Taita Taveta, Tana River, Tharaka Nithi, Trans Nzoia, and Vihiga. So that sums up the extras. So we are supposed to get into the rankings, but Adano, I can just proceed?
Yeah, you can proceed.
Okay.
Or unataka energizer? Unataka energizer? Okay, mko sawa? Haya, sawa, muendele. Unataka energizer? Okay, sawa. Martin, you can continue.
So for Cluster B rankings, I think one of us already knows their results, so we are not going to take so much time bringing suspense and all those things. So you already know where you are, Doc, and I'm sure before you even came, you already have strategies of how you're going to get out of this. Please don't go and sit with Malika for OJT on how to stay here, because he also escaped this slot, so wherever he is, he's happy. His slot has been taken away. Then next is Garissa. So Garissa looks like they have improved, from 44 to 42. So let me explain the numbers up there. The number in brackets was your scoring before last year. Then last year was 44, then current is 42. So that's what that top part means. So much as Garissa looks like they've marginally moved forward, this is still not good performance, and that is why the scorecard is giving you a red indication. So you need to work on a few things, but despite that, there are things you did very well, like TSR, which we have mentioned while looking at the presentation, low loss to follow-up rate, and good TSR among TIs. So you need to just work on other areas, especially data quality. In data quality, in some aspects, you didn't score very well. Next is Isiolo. So Isiolo moved from rank 6 to rank 32. And before all this, they were rank 25. They still did very well in maintaining a low death rate among DSTB cases. So for Isiolo, I think as you also evolve yourselves in terms of management, considering what happened, this is something you might also need to look at and see how best to improve. Much as the scorecard is not scoring you unfavorably, but you might need to see how best to address that. Now, so far, you'll notice that we have jumped from rank 42 to 32, sindio? So cluster A, B, walichukua hizo slots zote. Na pia 42 to 47, cluster A, B, walichukua hizo slots zote. So if you are here, you are above 32. That is what it means. Then number 2, I forgot to mention, Doc from Turkana, Kenya ilikupiga. Kenya was actually 47, you are 48. So Kenya was above you. So in where Kenya was, you remember the places where Kenya was scoring 5? So that is how Kenya probably came above. So as you also revisit this report, you look at that. Next is Taita Taveta. So Taita Taveta is, yes, moving forward, but at a very interesting pace, still ranked favorably by the scorecard, did very well in maintaining a low sample rejection rate, but their earlier rank was 22, dropped to 36, and now they are 31. Next is Kitui. So Kitui is getting lost, Earlier ranked 11, last year 22, now 30. So they are slowly disappearing, and they might move to the other cluster if they don't probably address a few things here and there. But they still did very well in Curate, and I'm sure you saw that earlier in the presentation. Then next is Kilifi. So Kilifi moved from 42 to 17, but now back in the 20s. They are ranked 28 currently. Still did very well in timely commodity reporting. But of course, I know Kilifi, this is not where you want to be, so there are a few things that you need to address. Next is Makueni. Makueni moved from rank 32 to rank 18, now rank 26. Still did very well in DSTB Curate, and we mentioned this. So you have started getting new strengths. You need to add more so that you move higher. Probably you improved your weights, but everyone else is also improving. So you are not able to move forward. Then next is Wajir. So Wajir is like a pendulum. Yeah, between 26, 10, 25, so maybe next year there'll be 10 again. They are just swinging between two positions. And of course, there's great potential in Wajir, considering you have TB Manyata and all those things. You can harness those opportunities and start performing even better, but you still did very well in terms of cure rate and TSR. Then next is Meru. So Meru, previously rank 24, dropped 25, now rank 20. Yeah, so actually for me, as I was looking at this, I was actually happy about Meru because I know the workload has also been going up every year. Whether you like it or not, Meru will increase the workload. So this is something positive for them and probably will get better as we move forward. Then next is Marsabit. So Marsabit slowly coming up. 35 to 27, now 18. But Marsabit has done this before. They came up like this, then disappeared again. But now we are seeing some sort of consistent trajectory, so you still have a lot to do in some areas, but we are happy with DSTB, TSR, and timely commodity reporting. Next is Tana River. Moving from rank 21 to 42, and now rank 17. So this is really massive improvement on their part. And it means that the team from Tana River sat down to address the issues we raised last year. So we hope that they can maintain this moving forward. Then next is Kisii. So Kisii somehow validates our scoring mechanism because they have maintained their rank. So for Kisii, previously you were rank 5, you dropped 15, and now you've stayed there. You're buying plots there, you're building rentals and all those things, instead of moving back to your rank. But of course, you still have a lot of strengths in maintaining low death rate among the RTB clients, a good cure rate, and also a good TSR, which are not easy to achieve. Then next is Embu. So Embu, ranked 17, moved to 11, and now 14. Still did very well in TSR among TIs and timely commodity reporting. So Embu, still a lot of potential. You are now becoming a teenager. This is teenager performance. You are stuck in the teens. So you need to move from this and probably go to the top 10. Next is Kisumu, and for these ones, I want us to really appreciate. So Kisumu was last year very sad. Yeah, they closed the chapter, but this time they have really, really improved. I don't know what you did, Malika. You might need, maybe in your section you shared best practices, but there's need to also have this conversation, just to know how you jumped all this way to this position. But now this also comes at a risk. Dropping is very easy. So you need to maintain. You need to maintain the milestones that you have achieved last year. And next is Mombasa. These ones also deserve an appreciation. So Mombasa is gradually moving towards something, yeah? 31, 26, and now 10. So there are people who have been whispering that Mombasa is the county to watch moving forward. I hope they maintain this, and probably moving forward they would have very favorable results. But this was good. You still did very well in low death rate and timely commodity reporting. Then how many have I not mentioned? Bado wengi, eh? Wangapi? Wengi, eh? Tuendelee kidogo. Okay. Next is Kwale, appreciation. So Kwale moved from 42 to 17, and now they are position 9. So this is something positive for them. And they did very well in DSTB TSR, maintaining a good cure rate and also a low sample rejection. Now, this is something interesting we noticed when we were analyzing this particular scorecard this year, is that the coastal counties are coming up. If you look at Kwale, if you look at Tana River, if you look at Mombasa, okay, Kilifi is trying its own things, gymnastics, is out Moazoea. So these other guys are moving towards the top. So it's something interesting. And remember, we've reached rank 9, and there's still one county from coast that I have not mentioned. So this is something positive for the entire region. Next is Tharaka Nithi. Hawa waliamua hawatoki hapa. So these ones are now settling here. You guys will come, you will pass, we are here. We're not going anywhere. And of course, we know how much potential this county has, because in our very first scorecard, I think they were ranked number 3. So I think the team from Tharaka Nithi, this is still commendable effort, but maybe you need to decide to have some motion towards the top. Okay? Then next is Lamu. So Lamu moving from rank 36 to rank 20 and now rank 7. So this is what I was saying about the coastal team. I don't know what's the common denominator, but there's been some sort of movement on that side. So Dine, Silamu ni majirani. Enda uibe max kwa kidogo, so that you also move to the top, okay? The next, Migori. Migori, there was a time you were ranked number 2. You scared everyone. You came from nowhere. Then you went back to nowhere. Rank 13, but now you are in rank 6. So this is also something positive for you. And I think we also know the kind of potential your team has. So you still did well on quite a number of indicators. I just listed a few. And I think there is still an opportunity for you to improve further. So up to that point, counties ngapi sija mention? 4, si ndio? So tunaenda quarterfinals, si ndio? Tumefika 6. Sasa tunaingia top 5. Yeah, but before we get to that, just a brief highlight on a county that probably we need to eliminate from the quarterfinals. Did very well in terms of proportionate scores of the weights, moving from 60.1 to 64.4. And you can see the list of things they did very well in. And of course, this will also be highlighted in the report that we'll be sharing. This was Laikipia County, which moved from rank 4 to rank 5. Okay? So what that essentially means is number 1, 2, 3, and 4 wako hapa, because we have eliminated one slot, sindio? Yeah, so but still for Laikipia, as we go along, you'll notice there is something uniquely positive for them. Then we were looking at, with the previous cluster, we looked at most improved sub-counties. Second most improved was Nyando, moving from rank 251 to rank 48. So this was really good. And I think, Malika, as you look at your sub-county performance, you'll notice a lot of movement from probably where previously you are to where you are right now. And the most improved sub-county who already went with the award was Butere from Kakamega. And they did quite well on a number of things that I have listed here. They moved from rank 273 to rank 9. And they also were the most improved based on the weights. Then best in quality of care. Third best was Mandera. And second best was Homa Bay. Okay? And these are all the quarterfinalists, indio? Yeah, but this county was ranked best in quality of care. And this is the most interesting thing about the scorecard this year. The person being ranked best in quality of care did not become the best. It means the other things are now, the dynamics of the other parts are now becoming really, really strong. It's not just about quality of care, we also need good data. We also need timely reporting and all those other things I mentioned in the extras. So Laikipia already went with this award. So if this is something one of you was waiting for, ishaenda. Okay? Yeah, so we move to the next. So the next county I'm going to mention scored 65.5% of the total weights. Did very well in DS and DR-TSR. QR rate was also very good for DS. Low loss to follow-up was good. And this means they maintained a low loss to follow-up of 2% and below. Also managed TIs very well. And of course, did very well in expert indicators. This county is Siaya County. So Siaya County is also on a trajectory. I don't know if you guys are noticing that. From rank 15 to rank 9, then now they are rank 4. So this is something very, very good for them. And also something I want to mention about Siaya is the weakness we noticed, the issue with bacteriologically confirmed. You really, really need to address that. I think you were the lowest among the 3 I mentioned. So that's something that took away points from you. Points that probably other counties gained. Okay? So, tumebaki na wangapi? Watatu. Which county and which county? Homa Bay, Nyamira, and Mandera, sindio? Among the ones who've remained, 2 have been crowned champions before. That's Mandera and Homa Bay, sindio? Now you know the scorecard does not strike the same county twice. So are we automatically saying Nyamira is the winner? Yes? It looks like that, eh? Let's see how it goes, okay? So, but before we go there, I want to take you on a detour. We need to know who was the most improved county, okay? There's been a lot of movement, so I want to distract you from the semifinals and the whatevers. Then we focus on this county. The 3rd most improved county was Busia, improving their proportionate scores as we have seen here, and also moving their rank from 41 to 13. But for Busia, it will also be very difficult to award them because they are also doing that pendulum thing. They come to 12, go back to 41, now they are 13. So I think there's just probably one part of their performance that sometimes clocks in, then it clocks out again. 2nd most improved was Kwale. Kwale, it means for the weights that we scored, Kwale moved from 40.9 to 58.8, moving their rank from 39 to rank 9. So there's also a lot of positive things to look at here. Then the most improved county, Nigani? Are you guys sure? So for the most improved award, I want to invite Dr. Sam Muga. Dr. Sam Muga is in the house? Yeah, you'll be the one presenting this award. The most improved county is Kisumu County. Okay, so I'm being informed 3rd, 2nd, and most improved kuna awards.
No.
Let's just confirm that before Kisumu comes. Eh?
No.
1 minute.
Improved county.
Because if that is the case, the others need to come.
Gani? The most? Okay, yeah. Na sub-county ziko? Yeah, iko sawa.
It's only one, eh?
No, it's
There are 3.
yeah.
Okay, there are 3. So, Doc, you will present the 3. So, we start with Kwale. Kwale wako wapi? Kwale team, tukuje kwa podium.
Wengine ni wale wa kupiga makofi kama mimi. Tupige makofi tafadhali.
And the partners wa Kwale pia. And if you live in another county and you are from Kwale, also come. Tunataka hii podium ijae.
No. Yeah, second most.
And their partners, please don't forget. Partners tuje tafadhali.
Director Kwale.
Jipange, jipange. Their photos supposed to be taken kindly. Partners. Okay. All right. Congratulations. Nimewambia sisi wengine ni wa makofi, eh? One day, one time, I will receive one. Okay. Thank you so much. Thank you so much, Team Kwale. As he presents that to the director, thank you so much. Very good. Very good. Thank you.
So the next is what? The most improved.
Kisumu. So.
Kisumu comes in style, yes? Naona Mary ameamua ako ready kusindikisha jirani. All right, all right, all right. All right. DJ, tumeenda Dala. Tafadhali. Eh? Tuko Dala. Hey, partners wako wapi bwana? We are happy for him. We are happy for him. Eh? He was the outgoing chair. Leona lazima atufurahishe. Hey, thank you, Malika. Okay. Kisumu. Okay. All right. Haya. Kindly. Okay. Because of time, kindly. Okay, for the wait. Wait, DJ, hapo kidogo. Okay, for the friends of Kisumu County, just one photo and then you leave the podium. All right, for friends of Kisumu, let's have one photo. We go. Friends of Kisumu, thank you so much. Namalika uende to number 1 sasa. Thank you. Aya. All right, so Kisumu, the partner, kindly. Right. Very good. Okay, so you can do one for Kisumu. Thank you so much. All right. Okay. Thank you so much. Thank you so much, Team Kisumu. Okay, let's... We are on. Still, the game is on. The game is on. We are almost sure who are the winners, but bado. All right, so Martin, you can continue from there.
So for the sub-counties, we are going to look at the 3 ranks. That is third best, second best, and the best, okay? So we'll start with third best. Third best sub-county from Kisii County. It's Kitui Chache North. And they did very well in quality of care. So for Kisii County, third best sub-county, this award will be presented by Benson Ulo from AMREF. So please, Team Kisii, your partners, tuje kwa podium.
Msichoke kupiga makofi tafadhali. Let's congratulate Team Kisii. No, makosa wakiekewe mbarambamba stage inaweza vunjika. I know I'm one of them. If I get here, you will see wonders. So, all right. Munajua bado kuna county ya Kisii region, so bado. Kazi iko bado. Okay. So this is for the third best sub-county. So you can go ahead and hand over. Okay, thank you so much. For the certificates, so you can also have an opportunity to receive that. I know those ones will be returned for them to be done calligraphy on. So thank you so much. All right. Mushaanza kuona second na first. I hope we are doing some probabilities on this. But now at this point, Martin, wewe ndio unaweza tuambia who are these?
Okay, so second best sub-county. Now this was interesting from a very different county, Makueni. Na naona CTLC wa Makueni yako story. Makueni, second best sub-county.
Hey,
were you not aware that you can get to that point?
Plus the implementing partners.
Any partner from Makueni? Because of time, kindly let's be faster. All right. Duncan Okado, kindly you can come over to hand over the certificates. Okay, was it like a shock because I don't see you happy, especially the CTLC. The CTLC was busy doing other things. All right, so good. Okay, you will be handing over that to Makueni sub-county. Yeah. All right, thank you for the good work. Thank you so much. For the certificates. Okay. Some concentration a bit for the photos. Thank you so much. Thank you so much. Let's clap for them as they leave stage. Okay, thank you. Thank you. Thank you so much. Higher, 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 higher. Number one.
So for the best sub-county, national ranking overall, this award will be presented by Rafael Pundo from Health IT. So the best sub-county nationally is Bomachoge Borabu from Kisii.
Hey, Kisii. It's a county to watch, eh? Moving forward. So, Omondi, you need to ask yourself. Ask yourself. DJ, tafuta muziki moja ya Kisii. Yeah? Tafuta muziki moja, lakini tafadhali take it lightly on this stage. Enyangi narora. Kyo enyangi narora. Ningonyoma. Can you join them? Okay. Very good. Okay. Thank you so much. Okay, thank you. All right, now, thanks DJ. Okay. Now let's concentrate for the photos. Thank you so much. Let's concentrate for the photo. Very good. Thank you. All right, thank you. As they go, as Martin gets to the stage for the next session. Thank you.
So just another additional bit of information is that the top 10 profile for the sub-counties, this is how it looks like. Machakos has 3 slots. Kisii has 3 slots. Nyamira has 2 slots. Makueni has 1 slot. And Kakamega has 1 slot. And I was also being informed by my colleagues that I might have skipped Machakos style in the scorecard. So I'll just mention exactly how it looks like in the report. So Machakos was previously ranked 7 nationally, but they have dropped to 39 nationally. So as of course we share the report, they'll get to see the areas that probably went down. But despite that, you can see in the top 10 ranking of the sub-counties, Machakos took as much of a share as Kisii. Now for those 2 counties, Machakos and Kisii, for me, my concern will be teamwork. It looks like there are people at the top and there are people somewhere else. That is why you have those discrepancies in terms of comparison. Then also remember what I said when we started the scorecard, that we analyze everybody's data independently. We don't assume that because a county is not doing well, there is no sub-county in that county that will do well. So that is the reality of the scoring at that particular point. So now we move back to the journey of the top 3, Sindio? Yeah, so we start with the 3rd best county. And as I'm explaining this, you will notice that even the best counties have weaknesses that are not really easy to ignore. The 3rd best county in timeliness was ranked last. It means they don't enter their data on time. They might have good data, but they're not entering their data on time. So this is probably why they were not the best, because in timeliness, they did very poorly. Then in accuracy, they did very well. They were ranked 3rd nationally, scoring 99% of the weights in that category. Then they still have areas that they need to improve on. That is timely commodity reporting. They did very poorly on that. Then also DR surveillance, not so bad, but considering how the other counties they are competing with were scoring, they were ranked 12th. And of course, they also dropped their case finding. Then, in terms of quality of care indicators, out of the total weights allocated in that category, they scored 24.4% of the weights. They were ranked 3rd nationally, did well in expert indicators. Commodity reporting, they scored the maximum weight. TPT